So Texas state share is very, very complicated. This is a chart that is a rainbow because I like rainbows. And it just goes through the different parts of the Medicaid state share that Texas puts in to how your doctor or how the managed care plan is reimbursed. So this is a lot of information, but just kind of to show that these are all of the little veins. And I won't be reading all of them, but some of them are just a payment that the state makes to a doctor. Some of them are one payment that the state makes to a managed care company, which is an insurance company. Some of them go to disproportionate share hospitals, so trying to make sure that hospitals are paid appropriately. And then there's a bunch of what are called supplemental payment programs. Some of these go to services with disabilities, some behavioral health services, some hospital reimbursement, and then the quality incentive payment program has some disability tie-in there as well. So just so you can see kind of how, see and understand kind of how complicated this really is. And depending on the policy you're talking about, you might be talking about actually one of these little veins of the funding as opposed to the general revenue part of the budget that Shannon was talking about. So it gets pretty complicated. And we can go to the next slide. So if you look here, in terms of who funds what, if we're talking about pregnancy coverage like we were before, just because that actually is one of the least complicated types of coverage that we have. There are two pie charts on this slide. One says Medicaid, and it has the blue state share at 40%, and then the FMAP, which is what the federal government puts in, at 60%. So in Medicaid, the federal government pays 60%. But on the pie chart that says CHIP, that yellow FMAP part is 80%. So depending on who is covered on which program, Texas actually gets more or less money into the state. In other states, we have done away with some of the, well, in other states, they've done away with some of the distinctions, so the state gets more money. Texas has not done that because they don't want to be covering as many people typically. So there's also other reimbursement schemes. In some cases, there's like a 90% federal match if a pregnant person is having smoking cessation services. So depending on what Congress has decided, this is all just completely arbitrary, what a state gets for what service for which people. So that's luckily we have a lot of federal partners who track that and we can get answers for you if you're interested in working on any of that kind of thing. So we can go to the next slide. So another kind of important piece of this that a lot of you are probably somewhat aware of or involved in is what happens when you or the state went from fee for service, so that's paying for each service separately, to managed care. So like most states, Texas transitioned from fee for service to mostly managed care organizations. These are private insurance companies that run our Medicaid program, for better or worse. I have my own opinions about that. I know that can get pretty tangly in a lot of disability communities, and for good reason. So in fee for service, if you're on the pregnancy coverage, there would be separate payments from the state and the federal government, so match for the ultrasound, blood work, meds, your hospital. In managed care, the managed care company does math on how much a pregnant person costs per month, and that's what the state pays them. So it's a per member per month. So funding schemes allowed under fee for service are not allowed under managed care structure, but Texas has kept using them anyway and using them more. So how we fund Medicaid in Texas is actually a little more complicated than the legislature deciding on an amount of money and funding the program. We have other ways of collecting money and using it that aren't actually reflected in what Shannon was talking about. And that's not because Shannon got anything wrong. It's because Texas does this on purpose to kind of hide the fact that there is more money and it's not necessarily going to healthcare for people. So we can go to the next slide. So the state share that Texas pays in, and this slide has a lovely picture of the Alamo, so no one forgets about that today. There are some budget line items for HHSC and the Medicaid program in the state budget, like Shannon said. The majority of funding for our state share actually is generated at the local level. That's something that a lot of people don't realize. So a lot of how Texas pays for Medicaid is through what are called local provider participation funds. These are a type of fee or tax. There's a lawsuit about that, so I won't comment on which I think it is. Um, but the state does have ability to bump up rates in Medicaid to Medicare rates by supplementing the reimbursement with these kinds of taxes. So a lot of the times that bill that people will be working on for, oh, we want like a higher number of attendant care hours or higher reimbursement for attendant care hours so the attendant care provider is paid more. That's not actually reflecting this other financing scheme that's going on because it's so complicated to work on. It's mostly accessed by groups like the provider physician groups that have a lot of lobbying and lawyers working for them. So that's just something to flag here. Um, there's an investigation into this. Whether or not that will continue after January, I don't know. But this is something to know that there is a lot of money going from what should be going to Medicaid and to specifically disability care that's going to business like hospitals and other parts of the state budget and not to healthcare. So I think that's important for this group to know. And we'll go to the next slide. This slide has a Longhorn on it. I went to UT, apologies. So different policy levers use different funding. So that's another thing that we like to say when we're talking to groups about budgets. Which policy you are talking about in Medicaid will have a different funding mechanism behind it. So there might be different parts of the federal or state budget. Sometimes if there's a policy change at the federal level, Congress will just fund it. The state doesn't have to do anything. Sometimes that's not true. Sometimes the state can make a policy change that gets no federal funding because they're innovating on something. So because of this, like a single healthcare transaction, especially like a more complicated one, like for a power wheelchair, that can be pretty complicated. There could be 5 or 6 different funding streams that go into just that one power wheelchair for the person with a disability who needs it. So that's also important to understand because some of the disability rights efforts get kind of held up because there's not as much understanding of, oh, we have to fix this federal thing, then the state thing, or, oh, this is in this kind of policy, so we have to fix this, then this, then this, then this. So that gets really frustrating. We can go to the next slide. So the top budget issues impacting people with disabilities, and I've worked in disability rights policy in multiple states, again, largely California, and a lot of these are pretty similar across states, actually. And on this slide, we have 3 Buc-ee's logos. One didn't add enough color, so the top issue is typically reimbursement across provider and waiver types, especially for home and community-based services. This can include or be related to caps on services that do not match needs. So as a lot of you may know, when states get a budget crunch, their first thing is like, oh, we're going to have a cap on attendant care hours. It's going to be 4 instead of 6, which doesn't actually meet people's needs. So because the legislature doesn't really understand exactly what that means for people and for families, so they'll cap services or, you can only have 5 therapy appointments in 6 months instead of 1 per month. So that tends to be a way that states try to save money because most Medicaid spending is on disability health care, even though enrollment is highest for children across the 50 states. Another issue is that family caregiver reimbursement is limited to specific programs and income levels, so not everyone qualifies for that. As Shannon mentioned, there's a big effort right now for funding our under-resourced eligibility and enrollment system that keeps people off coverage or kicks them out because our computers are so bad. We're working with Disability Rights Texas right now on their case with the Federal Trade Commission on the Deloitte software that's just not keeping people covered. They have certain clients with disabilities who keep applying for Medicaid. Everyone agrees that they qualify, they completely qualify, they have for years, and they just can't get enrolled in the system because the software is so bad. Texas does not opt into all allowable covered services under the Social Security Act, so we're not spending money on services that are important for people with disabilities, especially for being at their most integrated with the communities that are most important to them. And then, as it said in the chat, coming soon, there could be Medicaid financing changes at the federal level. So we'll go to the next slide. So the current existential threat, we have a rocket from NASA here on the slide that seemed pretty threatening, is a federal financing overhaul. So as we mentioned earlier, currently Medicaid is reimbursed at a certain percentage by the federal government. So if you have if you need the power wheelchair, the federal government, these are made up, might reimburse 80% and the state has to pay the remaining 20%. So there's a longstanding movement to change that so that the funds are either block granted or per capita capped, which means the state would get one chunk of federal money per year, or the state would get a certain amount of money for enrollee per year. The issues with these are that we don't know what's going to happen. So Tennessee has a block grant right now. And then the pandemic happened, and they had to keep all these people enrolled in Medicaid because of the policy that Shannon mentioned earlier. And they had to take all of that out of general revenue. So then that messed up a bunch of their budget because they only got a certain amount of money for, oh, we think Tennessee is going to have this many people, but then they had almost double that. And it also means that if federal changes happen, like maybe, something amazing will happen and Medicare will start to fund or start to cover hearing aids, and then Medicaid will follow suit. That's probably not going to happen. I'm sorry about that. But if that were to happen and we were block granted or per capita capped, we would have to pay for that out of state money instead of get federal reimbursement. So these are designed to limit the amount of people or services covered. And they'd be a really big issue in Texas because we only cover children, people with disabilities, the elderly, like maybe 1,200 parents in the whole state. That's how low our income eligibility limit is. I made that number up too. It feels like that at least. I should know that number at this point. And then people with disabilities. So they would have to cut services for people with disabilities to make this work if Texas opted into this, which makes it less likely that they will, I believe. But it's still really scary, and we're tracking this very closely at Every Texan. So we can keep in contact with y'all about that. And then the next slide. So the issues to watch for Congress and the Centers for Medicare and Medicaid Services right now are block granting, per capita cap, just like we talked about. This could really limit hope for improving the program. So a lot of our issues that we really care about that require money, the money might have to go to the fact that we've done this per capita cap or block grant. So we've cut services for people and we need to make that up. CMS may also undo a lot of good work from the last 4 years, especially more enforcement of the Americans with Disabilities Act in healthcare settings. In the previous Trump administration, most healthcare enforcement was targeted at HIPAA violations. And the Biden administration switched that back to, okay, yeah, that's important, but people can't access their doctor's office. That seems more important here. So we're looking at whether or not that will impact ADA enforcement at the federal level. Hopefully not, but we're working with disability rights partners on that as well. Then we can go to the next slide. And then for HHSC in Texas, this has a picture of Troy Aikman on it. I'm from Dallas. Apologies for that also. And For Texas, we have an opportunity now to make a historic investment in tiers and Your Texas benefits. So making Your Texas benefits better to improve how people get enrolled. So the agency has requested 400 million in staffing and tech updates, and advocates are rallying to get them this money. I can send the fact sheet that we've been using. We really do believe that making this change and getting this money, this one-time request, that the agency has will help people, especially people with disabilities, get better, quicker access to Medicaid when they qualify. And then most opportunities for state level work are going to depend on Congress and CMS. So we're just watching that and hoping for the best, but there's some pretty scary proposals out there. And then the next slide. Okay, our emails are on the slides. There are 2 questions in the chat. It is too complicated. That is on purpose. Not that I made it on purpose, but it is very complicated. A lot of people make a lot of money off of it being this complicated, and that's really unfortunate. And another thing that another team at Every Texan, our economic opportunity team, works on. But yeah, it's extremely complicated and it's really terrible. And I'm happy to be in the complicated stuff and translating whatever any of you need. It only needs to be one of us. I wouldn't recommend it. And then, yeah, Texas doesn't want to pay for anything. And yeah, the insurance options are very complicated. We do have resources at Every Texan for finding health insurance. It is open enrollment right now, so you might want to talk to one of the community navigators, Alicia. They can maybe help you find exactly what coverage you can qualify for, and some of it might be pretty low or no cost depending on federal subsidies that you could qualify for. So we do have that information. Let me try to find it and put it in the chat. But any other questions?
If not, Aaron, Shannon, Simona, thank you all so much. There's a reason why we asked them to come and explain the budget, even after all the years that all of us at CTD have worked on these issues. It just gets more and more complicated, and Every Texan has such a good focus on this area. That they are the best at looking through this and figuring it all out. If there's any other questions, we can always email them or in the future have another discussion. This is going to be a lively legislative session, and I think any big 4-year transition after a president election makes a difference in how our programs run. So there'll be a lot of work to do for all of us, and I think we're going to continue working on these issues to bring them forward to everyone. With that being said, I do want to thank our sponsors quickly since we're coming up on the hour, and that's Gilead Sciences, Grail, AstraZeneca, Sanofi, AbbVie, Pfizer, Amgen, United Healthcare, and Superior Health Plan. They've helped to cover some of the costs for us hosting these this year. We are working on our 2025 program, which is going to be more targeted at legislative advocacy and weekly updates that y'all can take action and bringing you up to speed. There's already been, I think, over 1,500 bills filed. I may be a little bit high on that for pre-file. There will be a lot more, and we'll continue looking and reading through those. We haven't had enough time to get through them all. And then I will leave y'all with one last thing. I think Sean is still on. If he is not, he may not be. But as of last week, Kenneth Simeon, who is on, was our board president at CTD. He is now, after his term, going to be our board secretary. And Sean Pesner, who was on earlier, will be our new board president. Sean is an attorney who went to UT, has lived experience, and will be an asset to everyone. And if there's ever anything we can do, or please let us know. Other than that, we will stay on for a few minutes extra to answer any last minute questions and go from there. Thank you all for joining.
I also want to mention while we're wrapping up that as this is our last Raise Your Voice call for the year, we are planning on reconvening next year in late January. I've been sending out a survey in the follow-up emails for y'all to just let us know what you like, what you don't like, what you'd like to see us do differently. So keep an eye out for that. And then we will be relaunching tentatively at this point on January 27th, once we kind of have an idea, a more solid idea of which way the wind is blowing after the legislature has gotten started. So you can expect to hear from us about what we'll be doing from January to May, early in the new year.
Thank y'all. Aaron, this is Chase. If you're still on, I got a quick question for you.
Sure.
Hey, at the end, you were saying the healthcare navigators. So at CTD, we've always had group insurance, and it's gotten, even on the private side, ridiculous. So we're looking at all the options out there. What does an organization that's a nonprofit, small, if they were to look towards going to the marketplace or something, is there someone beside, do navigators also help with that if you wanted to be an organization, or options available?
I'm actually not sure about that, but if you put your email in the chat, I'll find out and let you know.
All right.
It's getting so hard. It's almost better to be on Medicaid even compared to private
You have more
insurance.
protections. You
You
do.
know,
Yeah,
yeah.
sadly.
Yeah, we're seeing a lot of people where their out-of-pocket maximum is like a fourth or a fifth of their yearly salary, which is pretty sad and hard. It's catastrophic coverage basically now.
And you're still paying a lot of money.
Or their
I know.
employer is and no one's using it, which is also a waste. So yeah,
Yeah.
it's a hard conversation. Yeah, let
Yeah.
me
Because I've been shocked. Our premiums have always continued to climb, but now, even with our coverage, they're just not covering stuff anymore. Like all your diagnostic, all your labs, you're fighting for every medication. I had to pay for half my wheelchair because they wouldn't pay for side guards or the right front wheels. You start getting into these crazy, battles constantly. So we're trying to find out, is there a better option that's reasonably priced? Because paying a ton and not getting anything is about the same.
Yeah. No, I mean, you can understand why there's so many GoFundMe's. When I used a wheelchair, almost needed to do that, and I had private insurance. So, yeah, it was it's not fun at all. And it really is hard because so many people must be going without. Which is really demoralizing.
Yeah. There is a group that just started. They're like famous YouTube people, called It's Not a Wheelchair. And they actually are building out wheelchairs for under $1,000 with everything you need, but they only take cash. Which it works for someone who's already been in a chair and kind of knows their measurements and what they need. If you needed like the full workup, it's not the way to go. But for those who don't have insurance or have a crazy out of pocket, or can't wait a year to get a new chair, it's an option. So
yeah,
that's where they're pushing everyone nowadays. They know if they hold out long enough, you're going to have to pay for it.
Yeah. No, I mean, you'll appreciate when I had my first, I went to New Orleans pretty soon after and didn't realize you needed a different kind of tires for I had
Did
a
you
great
go out the
time.
front?
Yeah, my brothers had to push me around, which is why I'm helping with their wedding planning.
There
So
you go.
with them. Yeah. Yeah.
Understandable.
now I know there's different kinds of tires for that.
Yeah. Or else you just go the whole time. Yeah.
Yeah. Yeah. That was a lot.
Well, thank y'all again for everything y'all do. And this was great. Really appreciate it.
No problem.
Yeah, thank you so much for having us.
Yeah. And let us know if y'all need any help during session. We'll be there.
We will too.
Yeah, let us know if we can help on anything. We're giving federal updates to a lot of groups, so we can be sure to be sending them to y'all if it's helpful.
Yeah, definitely. And if y'all see any bills that are alarming to y'all, because they're going to be a couple thousand, and I'm sure there's only a handful that'll be alarming to all of us.
Mhm.
You know, if you want, just send them our way, and we'll look at them too. We're gonna start trying to get through them all.
Awesome.
It's kind of crazy in there. I've only
Oh,
gone through like about 600 just for some light reading. And it's terrifying in there. So
you made it farther than me. I made it through about 300, and that was really light looking at going, oh my, yeah, that one, I'm not gonna have to dig much deeper on that one. Yeah.
yeah, it was more so like let me look at the authors I like first before this gets scary. And then you start like keyword searching. You're just like, might as well just get into it. So
Yeah.
yeah.
Yeah. Excellent. No, it's gonna be a wild time, I think.
Mhm.
Yeah.
But we have each other.
We do, and we have to remember that.
Yeah, like that's actually so important right now.
And a happy hour. Yeah. There you go.
Yes. Okay.
Well, yell if y'all need anything. We really appreciate all of y'all, and we'll go from there.
All right. Thank you.
Yay.
Sounds good.
Okay.
Thank
Thank you
y'all.
all so
All
much.
right.
Bye.
Bye.